So welcome back to the last two sessions. One of our themes, or the theme, is start, scale, succeed. And so getting started, there were some great lessons and best practices you can learn from others and take away today. But what does scaling look like? And that's different depending on what your needs are. So we heard people talk about scaling into a centralized monitoring hub where instead of having individual monitoring stations at hospitals, they centralized it, a lot more efficiency with that, which was described across multiple hospitals in a centralized hub fashion. Others scaled in a different direction. They scaled from just Sitter and Falls to other patient settings and other patient populations. So we heard about a locked behavioral health unit at Froedtert. We heard about seizure patients. We heard about multiple different use cases in the emergency department and ICU. And Dana mentioned we recently did a webinar really focused on children's hospitals and pediatrics. So that's a different way to scale, which would be different settings and different patient populations. Now I'm really excited for the next session, which is scaling in yet another direction. And that is from patient safety, which is what virtual sitting is focused on, into patient quality and patient experience and nursing satisfaction with virtual nursing. So I'm very excited to tee up this video interview that I did last Friday with Matthew Hempel at Holzer Health. He wasn't able to be here live today, but let's hear the conversation that he and I had last Friday.
Well, I'm really excited today to talk with Matthew Hempel. He has a master's in nursing and CNML and is the director of acute care nursing at Holzer Health System. He has over 14 years of nursing experience, in the last 11 in nursing administration. He started as a supervisor role, then a med-surg unit manager. And your educational kind of path is one that I've heard from other nurses, and I love it. Just kind of like a lifelong learning. First one thing, then the next. So you started with your associate's degree in nursing at University of Rio Grande and immediately went on to Ohio University for bachelor's, which you completed in 2011. And then you didn't stop there. Like, oh, maybe one more. And so went on to get your Master's of Science in Nursing Administration at Marshall University. So, and I guess always lived in Ohio and focused your career in the Holzer Health System. And one of your areas is virtual nursing and virtual sitting for the organization. And so welcome and thank you for sharing your story with us today.
Yes, thank you for inviting me. I'm really excited. This is a very new program for us, and we're getting started, and we're excited about the future.
Yeah. So just tell us a little bit about Gallipolis and Jackson and how the sort of sister hospitals are set up there, to give us some context.
Yeah, sure. So Holzer Health System is made up of 2 inpatient facilities, 2 hospitals. One's critical access, and that is in our sister facility in Jackson, Ohio. But our main campus is in Gallipolis, Ohio. That's our main inpatient unit. We also have some ambulatory branches as well as some post-acute service line as well. The hospitals are about 30 minutes apart. So we're still pretty close to each other, but it's a little bit of a distance.
But I'm in the sort of rural hospital, I guess we would say, and it's important for your patients that you serve that they have access, like it improves their access if they're able to go to Jackson, if that's closer to where they live. And that's what I kind of like about your story is patient access and improving that.
Right. We are kind of a smaller rural community hospital. Kind of our more tertiary centers is about 2 hours away in Columbus, Ohio. And we want to keep as many of our patients in our community here. You know, we try not to transfer anyone out. If it's a service line that we can provide, we definitely want to do that for our population.
And that, I think that is a great use case for virtual care in many ways, just to improve access to patients in rural settings. So walk me through your thought process as an organization to invest in virtual sitting, and then, you know, kind of launch virtual nursing, getting started in that. What were the problems that prompted you to pursue it?
Well, just like pretty much every healthcare facility in the country, we have staffing issues.
Mhm.
We had a small one-on-one sitter pool,
Yeah.
and it was difficult staffing as well. But you know, we realize we have a lot of needs that were going unmet, and a lot of patients that should have had extra eyes on them that we just really couldn't provide. And it really kind of exacerbated throughout the pandemic. And that's when we really started looking and determined, you know, what can we do with less staff, but also have a pair of eyes on a larger volume of patients. And we did a lot of exploring, and we kind of found a couple of different telesitter virtual models that we looked at, and you know, Avasure really kind of connected with us and kind of met the needs that we were looking and hoping to implement. What really kind of helped us from the get-go is we did apply for a grant, and we did receive a grant, and that kind of helped start the process, gave us a little bit more financial support to get the program started.
What type of a grant was that?
It was a rural, I can't remember if it was exactly specific to Ohio or Appalachia, but it was a rural community hospital grant. And then we have an actual grant writer on staff here at Holzer, but through him and our chief strategic officer, they were able to successfully receive this grant for us.
That's fantastic. And as you should, you know, because that goes a long way to providing better care for the patients that you serve. So just describe how many devices you have and how do you split them up and
Sure. So we have a total of 16 devices, and I know that may not sound a lot, like a lot, but for our size facility, it's really proved to work out well. So we kind of set two mobile devices aside for virtual consults, and then the other 14 are well, there's 12 that are 10 that are mobile units, and then the other two are permanent ceiling tile units. We got 2 in our ED here in Gallipolis and 2 in our ED in Jackson. And then we have 10 that are just mobile.
Okay. Yeah, I hear that a lot, to do ceiling tiles in the emergency department because the turnover is just really fast, and
Yep.
that makes a lot of sense. So what I'm really interested to kind of dive deeper with you is about the virtual consults. So yeah, tell us about that program.
So that was really a selling point from administration. That was something they were really interested in, as well as our providers. But I will say that was kind of implemented after the fact. So we started with the telesitter program,
Yeah.
and that was our original start process, and then we added the consults. And it's still going a little bit of a slow build, but we have some providers and some specialty nurses that are really taking advantage of it and kind of, you know, grabbed the bull by the horns and has taken off with it. But some of the other specialties are kind of a slow build. We have, again, small rural facility, and we have a lot of tenured providers, especially in specialty areas. That, you know, they're kind of slowly moving to this virtual world, but we're getting there.
Talk a little bit about the woundostomy nurse and how that's been working.
Yeah, so we really only have one wound
Mhm.
ostomy nurse and one diabetic educator, and they're based here at the main campus in Gallipolis. And there were a lot of consults coming their way from our Jackson facility, which is about 30 minutes away. And that they'd have to stop whatever they're doing here at the main, address the consults, potentially they call and contact the nurse, and the nurse tries to describe what was going on, but or the wound or whatever it was, and it just wasn't a real clear picture. They ended up driving 30 minutes to
Yes.
Jackson, seeing the patient, doing the consult, driving back, and trying to, see the rest of their patients here. So we tried to think what we could do to help these guys out. So we implemented the virtual nursing with them, and now they have a mobile device up on our main med surg floor in Jackson, and they just connect. They see the patient, they can see the wound, they can make recommendations. We have the same, medical record and everything, so they can put their consult notes in and their recommendations, and they're good to go. They eliminated that entire drive, 30 minutes up, 30 minutes back, and the time it takes to see those patients. So we've utilized that for the wound nurse and the diabetic educators, and it's worked really well.
I love nursing specialties. And I think that is one of the key benefits of virtual care is the specialization that occurs. Even if it's admission discharge virtual nursing, which you're not doing, some other organizations are doing admission and discharge virtual nursing, that nurse gets really good at discharges and really good at it, the admission process, and the woundostomy and the diabetic educator are working at the top of their training and skill set. And their time is not well spent behind the windshield of their car. So that makes complete sense. Tell me, what providers, other providers are embracing it? You said some are slower to, like, who are the specialties or personalities that are kind of embracing this on the physician side?
So really two specialties is really kind of taken off with it, and that's neurology and nephrology.
Okay.
And I would say neurology has kind of been our provider champion. She's invited me to come, and this is Dr. McConnell, and she's invited me to come to her medical director meetings, and I've presented there. But she's kind of our provider champion. She provided an example, before we went live with this program. She was on call. It was a weekend, and she doesn't live very far away, but it's a little bit of a drive, maybe 20 minutes or so. But nursing staff kept contacting her regarding a patient, and the patient just kept having it was a seizure type activity. They tried to describe it to her, but she was never able to see it. And she said, if we had something virtually that I can just connect and they have it right there in front of the patient, I can actually see what they're describing. And that would help, provide the plan of care for this patient. So that was, I think, one big reason as to why she really embraced it. And she has utilized it several times. We initially wanted to be able to provide this for specialty consults to help with the discharge process. So, we have a hospitalist program, and they'll write, they'll do all the discharge work. But if we were waiting, pending consults or pending stress tests or anything like that, that's going to hold the patient up from getting discharged. So our idea with the consult piece is not to take place of their normal rounding or their normal consult process, but to supplement and to help facilitate discharges, which obviously helps down the line, helps get patients out, the turnover of patients. We don't have holds waiting in the ED. So that's kind of the mindset behind it. And if we can contact neurology, that's the only hold up is waiting on a consult from neurology. she can connect, watch the patient, like, oh, this patient I need to see, or this patient I can see outpatient with an appointment tomorrow. So that's really kind of helped us speed up our discharge process.
And your answer is kind of leading me to the next question. And I'm imagining this is where you're thinking next, is to kind of capture some outcome metrics on maybe length of stay or physician satisfaction, or what are you thinking about where you're going to go next as far as tracking some of those outcomes?
Absolutely. The metrics, we have a patient flow committee, and we report out a lot of, our length of stay, our consult times, readmissions, things like that. We're still early on in this process, and we want to hardwire and make sure we can get it adopted in a lot of the other specialty units. But those are the type of metrics I think is really going to have an impact. Especially, you mentioned provider satisfaction.
Yeah.
And it's funny because the ones that are using it seem to really like it, and they're trying to get their colleagues and their peers to adopt it more as well. So I think all of those metrics are going to be impacted by this program, and as it grows, it'll be more evident.
Absolutely. What kind of feedback are you getting from the bedside nurses?
Well, the nurses, it really doesn't impact their flow too much at all. The device, all you got to do is put it in the room and plug it in. Really. It's sometimes helpful to have the nurse with them because they have to turn the patient or anything like that, or if there's a question the patient can't hear or anything like that. There's some patients that it's just not going to be appropriate for. But a lot of them, I think they are. But nursing seems to like it because they're not sitting around sending messages to the provider, trying to wait and find out if they're going to come see the patient. They got family calling, hey, when is Dr. So-and-so going to be here? So the provider, once they get a consult and they want to do this virtually, they call the floor and says, I will be available and I want to have a virtual consult at X time. So that way they can communicate that to the patient and the family. And then at X time, they have that mobile device in the room plugged in, and they can have that consult then. So really, it's a minimal time to the nursing staff. If they're available, they'll come and get the mobile device. If not, the nursing supervisor, or, another unlicensed personnel can take it up to the room. So that's really the bulk of their time.
Yeah. So they don't. Yeah, I think the ability for the provider and to pan, tilt, zoom the cameras is super helpful. So they're not having to hold an iPad, move it to the left, move to the right, no, angle it down, no, get some light, so that's really key. And have you had any feedback from patients?
I remember when we were early on going live with the program, we were kind of, I was involved in setting up with the mobile unit itself, and talked to the patient, and they're like, well, this is a little strange because, small rural community, that's something they haven't really, we have a stroke robot with a bigger facility in our ED, but that's the only kind of real experience that our patients may have with virtual technology. So once I kind of explained the situation to them, like, oh, okay, I understand. And then I kind of left, and they did the virtual consult, and I came back in and picked it up. And I said, well, that was easy. She's like, the patient was like, I didn't, fully understand, but, I could see the provider, I could talk to them, we really didn't have any issues. So that was great to hear. I haven't really followed up or gotten any other feedback. And sometimes they say no news is good news. So if everything's working as it should, then hopefully you won't hear anything bad. But patients seem to work well for patients and staff.
Yeah, and I think over the past few years, we all have gotten used to an expectation for more virtual care. Even just in an outpatient way, direct to consumer. So I'm not surprised to hear that. I'm going to put you on the spot for something. I see over your shoulder, it says I Care Nursing Care Model. I wonder if you thought about how virtual sitting and virtual nursing fit into your nursing care model.
So our eye care model has been kind of our standards of behavior for
Yes.
nursing for quite some time. And as recently, within the last 6 to 7 months, each service line has put together and adopted our own models of care.
Oh,
So each service line is a little bit different, but acute care nursing, it's nothing new. I mean, the
Yeah.
same thing, bedside rounding, bedside report. I mean, all of that stuff, leadership rounding, all of that is stuff
The
that we
basics.
already do. Yeah.
yeah.
This is just more or less providing some organization to it. And I do see where, virtual nursing has a role in our care model. We're not, just like I said before, we're still early on in this.
Yeah.
And I think we have a lot of things in the future that we can expand on. But being able to give that personalized care, that's personalization is a big part of our care model. Having them involved, our patients involved with virtual nursing, it really, I think, has a big impact on their overall experience here at Holzer.
Yeah. Yeah. And I think meeting, I imagine that having access to some of those specialty from the critical access hospital gets them back home to their families faster. And, it is kind of patient centered.
Yeah.
They get access to what's available at the bigger hospital, but closer to their home. So that's fantastic. And then we always kind of give the opportunity whenever we're doing a webinar presentation to share any good catch story that you may have from virtual sitting. And you were telling me about an interesting case that happened with you before.
Yeah, I did. And this one was interesting, and it's not the reason for the program. It was more of an incidental finding. But we had a patient that wasn't, necessarily alert and oriented. I mean, they were able to speak to the telesitter and things like that, but they had a lot of visitors. And I can't remember if they were actual family members or just visitors, but they had a virtual sitter. And we discovered that they were basically taking everything that wasn't nailed down. So they were, everything down to light bulbs. They were just taking light bulbs out, putting them in bags. And so once we got alerted of this from the virtual nurse, like, hey, this isn't, something's not right here. So we got security involved and it got addressed. So I know that's an odd story, but it wasn't, the purpose of the program. It was definitely an incidental finding.
It's surprising what happens in a patient room.
Yeah.
So thank you for all that you're doing and your innovation and what you're doing to improve access to care for patients in your area. And thanks for sharing with us.
Yeah, absolutely. Again, I appreciate the opportunity. Really excited about where we're at now and where we're going to go in the future, because this is just the beginning, and I anticipate expanding in other areas and expanding with other specialties and really having a robust program.
All right. Thanks, Matthew.
Thank you.
Okay, that was such a fun conversation that I had recently with Matthew. And what I noticed here watching it, because I was live when I interviewed him last Friday, was how often he used the word connect. And I don't know if that was subconscious or not, but what he is pioneering within Holzer Health and some others in our customer base is Avasure Connect, which is the virtual nursing platform that we have for that one-to-one, two-way interaction that he was describing, that Dr. McConnell, the neurologist there, and the nephrologist and the wound ostomy nurse and the diabetes educator could really help their more rural hospital get access to that specialty care and help them get out sooner and then stay closer to their home. So that was a great outcomes that they're getting in Ohio. And Matthew Hemphill and I will be presenting at the Academy of Med-Surg Nursing Conference in Las Vegas. September 19th through 23rd is the conference, and they have a whole virtual nursing track. And I think that will be a phenomenal conference, and I'm excited to present with him even more detail.